So I'm supposed to talk about conventional knee replacements. Now, before I start advocating conventional, I need to tell you what conventional is. It's a traditional method of resurfacing of the knee, which has been going on for decades, with favorable outcome, good background and follow-up data, easy to learn, teach, and has been reproducible. And that is why most of the registries have shown that still more than 80% of cases are being done conventionally. Not only that, randomized trials in largest case series back conventional arthroplasty. Now, my friend's going to tell you a lot of nitty-gritties about PSIs and gender-specific implants and high-flex knees. So I'm not going to delve into that. I'm just going to tell you a little bit about the evidence. So what's PSI? I'm sure Aamer will give us a bit more detail on it, but essentially it's patient-specific instrumentation based on pre-operative templating and 3D printed cutting guides. So what's the evidence? Now this meta-analysis based on over 3,000 cases and 1-year follow-up for function and surgery time, blood loss, and complications has shown no difference. And whether it's cost effective or not, this study from Germany looked at the economical factors. Not only that, radiological alignment, patient-reported outcomes, and still came up with the same idea. Yes, it does use less resources, but that does not offset the cost of the technology itself. Now, coming to the female-specific implants, yeah, we understand that females are not males. They have different anatomy. But are we selling just this implant to the females? Well, first of all, we need to know, why do we need to change? Are females doing worse? By looking at all the largest registries, whether it's the NJR or the Australian registry, or one of the largest US data, actually it's men who are at higher risk than females. So why change? Now, this large prospective study looks at whether the gender has any effect on the outcome. Now, in terms of improvement in function and flexion, actually it were women who were doing better. Pain relief, walking improvements, and implant survival, no difference. Yeah, overhang has been an issue, but it can be dealt with obviously careful preoperative planning. This study looked at whether overhang had any effect on function, whether it's clinical or radiological. Again, no difference. Overstuffing of the patellofemoral joint, anterior knee pain was also looked at. Again, it wasn't significant. Now, this is a systematic review presented quite recently, and this is based on results of multiple RCTs. And again, the result is the same. Yes, the femoral component overhang is an issue, but it does not translate into functional or radiological outcomes. Now, next I move on to high flex knees. Now, yeah, there are some indications for high flex because we're getting more and more younger patients. There are some cultural reasons as well and religious reasons. But it's not just the implant that will change the post-operative flexion. In that list, you can see there are a number of factors which can affect the results of the flexion of a knee post-operatively. So why just change the implant and expect a better outcome? Now, do we really need a high flex knee? Because more than 75% of the registry data is based on standard knees. And most of the patients that we have, 65 plus, do they need that much of flexion? Is function any better? According to Runnerwoods from HSS, they looked at 1-year follow-up of high flex knees and particularly looked at their function in deep flexion. They looked at whether the patients could squat, whether they could sit on their heels, and whether they could kneel. Well, 30% couldn't squat, 50% couldn't sit on their heels, and 40% couldn't kneel. And of this cohort, 20% could not do either. So is it really worth going for a high flex knee? Now, this randomized controlled trial from Australia again gives us the same message. High flex knees had better pre-op flexion to begin with. So again, a flawed result. Now, the range of motion, this meta-analysis looks into 9 comparative studies, and 5 of them showed better range of motion with high flex knees. But again, when you look at this paper in detail, there were a lot of methodological errors. Now, what about the long-term outcome? Again, this is a 16-year-old follow-up of high flex knees compared to standard conventional knees. If you look at the highlighted range of motion at 16 years, the high flex group was 115 degrees, and the standard group was 113 degrees. And there was no difference in the range of motion, joint stability, or function. In fact, the failure rate was higher in the high flex group. So in conclusion, I could go for a conventional knee in most of my cases. PSI may have some indications, but cost is an issue. And literature does not support routine use of high flex, PSI, or gender-specific implants.
Thank you very much.